So today we have topics regarding orthopedics, and here we begin. The term orthopedics was coined by Nicholas Henry. So he was known as father of orthopedics. So we have Nicholas Henry, father of orthopedics, but the father of modern orthopedics is Robert Jones. Uh, and the term ortho means straight and pedics means child. So the orthopedics means straight child. And defining orthopedics, we get it is we can say it is a branch of surgery that deals with prevention or correction of injuries or disorders of skeletal systems and associated muscles, joints, and ligaments. So it's a branch of surgery that not only deals with skeletal system but also with uh, associated muscles, joints, and ligaments. And talking about role of imaging in orthopedics, we know that X-ray is the first radiological investigation in traumatic disorder. If any patient comes with traumatic disorder, then first investigation that is to be done is X-ray. It uses screening of cortex and marrow. Uh, Later we will see in image. This X-ray uses screening of cortex and marrow. Also soft tissue planes, that is muscle and fat planes, are visualized. And this loss of soft tissue plane is earliest X-ray changes in infection or swelling in limbs, and it is seen after 24 to 48 hours after onset of infection. It This changes relates more to the infection than tumor. In this image we can see here, cortex is the lateral part, and in the middle we have cavity that contains marrow, uh, and this one is a muscle layer, and outer to this muscle layer we get fat layer, and both these muscle and fat layer comes under soft tissue plane. So we must not neglect this too, that is fat outside. We have fat, and inside we have muscle layer, and both comprises soft tissue plane. And in this image, in the left image, we can see joint space, gap between the two bones, and that is generally cartilage. As we cannot see cartilage in X-rays, so we get to see space in between the two bones. And what extra we can see on X-rays? Glass pieces are also visualized due to presence of lead in them. Means we can see glass pieces, but cartilage is not seen on X-ray. That's why in the previous image we got to see joint space. And important thing here, we have joint space is a misnomer. Actually there is no space in areas of joint. It is a cartilage occupied area. That area is the cartilage occupied area, which is not visualized on X-ray. Thus, whenever joint is destroyed, cartilage is destroyed. Hence, joint space is reduced on X-ray. So, whenever we find little joint space, then we must understand that cartilage has been destroyed. And here we can see difference between ossified tissues and calcified tissues. Ossified tissue means live bone, and calcified tissue means dead bone. So we can compare live bone with brick wall and calcified or dead bone with chalk. So in live bone we can see architecture of Haverson and Volkmann's canal. Here in calcified tissue or dead tissue, there is deposition of calcium, but without architecture or trabeculae. And in live bone, on X-ray, live bone looks less white, and on X-ray, dead bone looks more white. See here we can see chalk is more white, and ossified tissue is like brick. and architecture is maintained. And here we can see uh, in dead bone or necrotic bone, we can see this white part more white than the surrounding areas. So means relatively this is more whiter than this area. So this area is dead part, that is sclerosed. And now we have periosteum. Periosteum has two layers, outer fibrous layer, that is non-functional, and inner we have cambium layer, that is cellular or active layer. Now inner layer is more important, so we have to discuss about cambium layer. So it has got many roles and important roles. We can see here it helps in bone reunion. It helps in bone union at fracture site by providing osteoprogenitor cells. And if deficient, bone union is difficult. Example, in neck of femur, cambium layer is universally absent. Hence, this is one of the causes of higher rates of non-union in femoral neck of fracture. So, if we get fracture at the neck of femur, then there is higher chance of non-union because it lacks cambium layer. And as cambium layer helps in bone union by providing osteoprogenitor cells. So if it is deficient, then bone union is difficult. And another one is origin of bone tumors. As the cell layer is cellular or living or active, we can say this is more prone to give origin to bone tumor. As this has cellular activity, so it can give rise to bone tumor. Example, osteochondroma. And during treatment, tumor excision along with periosteum has to be taken out. Means tumor excision means periosteum has also to be taken out surgically, and if it is not taken out, then it leads to recurrence. And the third one is periosteal reaction. Periosteal reaction. Whenever disease pathology destroys the bone, cambium layer is irritated and respond by periosteal reaction. Periosteal reaction means bone formation in under periosteum. Thus, periosteal reaction is an indicator that disease is destroying the bone. So now we can here we have to read about periosteal reaction types. So first type is no reaction. Means for example, you can see in tuberculosis of bone, this reaction is not present. And in second type, narrow zone of activity. Example, solid periosteal reaction. Means single layer of periosteal elevation is seen in benign lesion like benign tumor of pyogenic osteomyelitis. And third one is wide area of activity. This occurs in malignant case. So here we have altogether three types. First is there is no reaction. Means in tuberculosis of bone we do not see this periosteal reaction, though it is infection. And in second type we get in benign lesion, that is narrow zone of activities is seen in benign lesion, and wide is in malignant. Narrow in benign lesion, wide in malignant lesion. For example, onion peel or Codman's triangle and front ray appearance, we get to see malignant lesions. We can see in image this solid periosteal reaction. This is a narrow activity. See, we can see a single. It occurs in benign lesion. In single layer of periosteal elevation is seen. See, this is a narrow zone activity. And here we can see onion peel reaction. This is seen in malignant or chronic cases, usually even sarcoma. And here we can see Codman's triangle. The triangular bony growth seen at angle of lifting of periosteum. It can be seen in any malignant lesion, but usually osteosarcoma. Here, onion peel in Ewing sarcoma, cornea strangle in osteosarcoma, and sun ray or periosteal react, sun ray or sunburst or speculated periosteal reaction. And this is calcification along surface fibers, and it can be seen in malignant lesion, but it is osteosarcoma. Here we see surface fibers. These are the perforated fibers that connect outer periosteum to the inner bony part. And, calcification along surface fibers is seen. Here we can see sun ray or sunburst periosteal reaction. Now we are dealing with some terms like osteophytes and syndesmophytes. Here osteo means bone and phytes means growth, and they are seen in case of joint damage. Osteophytes are seen in case of joint damage. Reduced joint space also indicates joint damage, as joint space is cartilage. Yes, as we have already discussed about joint space, as it is cartilaginous space, cartilage or filly area, joint space, and reduced joint space indicates joint damage. And syndesmophytes, it indicates spine destruction. It is osteophytes of spine, but there is slight difference between osteophytes and syndesmophytes. Syndesmophytes, they breathe across joint as compared to the osteophytes, which are non-breathing. Means osteophytes are non-breathing, but syndesmophytes are breathing. In image we can see osteophytes, and it's seen in case of joint damage. As we discussed, in case of joint damage, growth can be seen. So here in joint damage, the growths are seen, and this is syndesmophytes. This breathing is not so clear. Here in this image we can see breathing. Here breathing has occurred. So this is the difference between syndesmophytes and osteophytes. This lacks in osteophytes. Now discussing about ultrasound. It uses high frequency transducers, 5 to 12 megahertz, and it has a benefit that it can be used in evaluation of soft tissue near metallic orthopedic hardware. That limits MR imaging. Means we can use USC near metallic transplants, something like that. And MRI name itself suggests magnetic resonant imaging. MRI cannot be done if ferromagnetic substances have been embedded in the body, means iron containing or ferromagnetic substances has been implanted on the body, which limits the use of MRI. And USC is useful in evaluation of muscles and tendons. And MRI has replaced for many indications of USC. CT scan can be used for does the investigation for cortex and calcification. C and C for CT scan, C for cortex, C for calcification. So any newborn formation or 3D image, CT scan is preferred in investigation. So any newborn formation or 3D image, CT scan is preferred. And MRI is the investigation of choice for marrow, and for MRI and for marrow, and soft tissue like brain, spinal cord, ligaments, tendons, vessels, and cartilage. Mostly marrow, cartilage, and soft tissues. Any occult fracture, that is not visualized on X-ray. Example, fracture neck of femur. MRI is investigation of choice. And any fracture in which there is marrow edema, this marrow is involved. Example, stress fracture. MRI is investigation of choice. And osteomyelitis also starts in the marrow of metaphysis. So marrow is involved. So MRI is best radiological investigation. And tumors with marrow involvement, any micrometastasis or soft tissue components, soft tissue like brain, spinal cord, MRI can aid in diagnosis. And in avascular necrosis or Portis disease, avascular necrosis of femoral epiphysis, also MRI is investigation of choice. Here we can compare CT scan with MRI. CT scan can principally show only the bony structures. Only bony structures. Here in the left image, on the left side we can see CT scan, only bony structures as visible, and on the right side we can see soft tissues very well, and this is the MRI. On the right side, soft tissues are also visible, and this is bone scan. And bone scan is done to see the metastasis of tumor all over the skeletal system or body, or whether metastasis over the bone is secondary from other sides. Means bone scan is used in case of metastasis finding. So bone scan shows activities in areas with increased osteoblastic activity, example tumors, infection or fracture. Thus, in cases with bilateral stress fracture, bone scan is preferred investigation. Bilateral means see here we had discussed stress fracture in which there is marrow edema, and investigation of choice for unilateral stress fracture is MRI, and bilateral is bone scan. It can pick up tumors that grow from one bone to other, that is bone to bone metastasis, bone to bone osteosarcoma or neuroblastoma, even sarcoma. Here we can see we have mnemonics for it, bone to bone metastasis or osteosarcoma, or and for neuroblastoma, even sarcoma. Maximum incidence is in even sarcoma. So bone bone scan is used in case of this bone mnemonics. We have bone, and limitation is that bone scan cannot identify source of unknown primary. Yeah, it's limitation that it cannot find the source of unknown primary source. And lesion with lytic activity do not show activity on bone scan. Here what we have discussed is that increased osteoblastic activities, osteoblastic, and here lytic activity. Blastic activity can be shown, can be seen in bone scan, but lytic activity do not show activity on bone scan. Example, multiple myeloma. And next we have PET-CT, means position emission tomography plus CT scan for whole body. This is combination of two modalities. 18F-deoxyglucose is taken up by tumor cells as they have anaerobic metabolism, and CT scan for all viscera, so it can identify unknown primary. What we discussed was that in case of bone scan, the uptake is by osteoblast, and in PET scan, it is by tumor cells. Tumor cells. This is important point. Bone scan. In bone scan, the uptake is by osteoblast, and PET scan, it is by tumor cells. Thus, PET-CT is more useful than bone scan as it can identify primary and is more specific for tumor cells. Bone scan cannot identify primary because it cannot in bone scan dye is not uptaken by by tumor cells. Rather in bone scan dye is uptaken by taken up by osteoblast. So primary source cannot be identified in bone scan, but in PET-CT, PET dye is taken up by tumor cells, so we can identify primary source. And limitation is that osteoplastic lesions have limited uptake on PET, so bone scan may be more valuable. So in case of osteoblastic lesion, as dye is taken up by osteoblasts in case of bone scan, so bone scan is more valuable in case of osteoblastic lesion. And metastasis, for metastasis single lesion we can use MRI, and multiple osteoblastic metastasis we use bone scan. Multiple metastasis can be find out by PET scan. And most important thing is that radiological diagnosis in cases of infection and tumors is suggestive, never diagnostic. And diagnostic is always tissue diagnosis. It means that tumors and infection can mimic each other clinically and radiologically. Example, for example, osteosarcoma and ameosarcoma are two tumors that mimic osteomyelitis, and osteomyelitis is infection. Both have accompanying fever and increased local temperature. So tumor and bone infection are usually metaphyseal and both need tissue diagnosis for differential. Thus, culture is gold standard for infection. Histopathology is gold standard for tumors. So rule is culture or biopsy, and biopsy or culture. That is, whenever you obtain any sample from a suspected case, tumor or infection, divide it into two parts and send one for culture and other for histopathology. Infection tumor, biopsy taken, one part is for culture and another is for histology. And culture identifies infection and histo identifies tumor. This has to be done, both culture and histopathology has to be done, because many tumors mimics infection, like osteosarcoma and ameosarcoma are tumors, but they mimic osteomyelitis, and that is infection. So rule is culture or biopsy, and biopsy all cultures. Now in case of osteomyelitis, that is infection, pyogenic osteomyelitis on X-ray will show loss of soft tissue planes. Soft tissue planes means muscles and fat layers after 24 to 48 hours. This is the first change in case of osteomyelitis. That is, pyogenic osteomyelitis on X-ray will show loss of soft tissue planes, as we had seen here. Soft tissue plane means muscle layer, this one, and fat layer, outer one. So, and day 7 to 10, solid periosteal reaction is identified. Solid one, narrow activity, as we already discussed. The first bony change is this solid periosteal reaction. And in tuberculosis, there is no periosteal reaction, as already discussed. In case of chronic osteomyelitis, sclerosed dead bone, and this is seen as more white than nearby bony parts, as we already discussed. This sclerosed dead bone means more what is seen on white X-ray. And this question is important for diagnosis. And onion peel appearance is the usual periosteal reaction. Onion peel appearance. We also seen in sarcoma. MRI can pick up marrow changes in metaphysis, and MRI. Best radiological investigation for osteomyelitis and tuberculosis is MRI. Bone scan is next in preference to MRI to pick up infection by picking osteoblastic activity at the site of infection. As we already discussed, osteoblastic activity, bone scan is good, because the dye is taken up by osteoblast in case of bone scan, and MRI in case, and so bone scan is next in preference to MRI. Bone scan is next in preference to MRI to pick up infections by picking osteoblastic activity at the site of infection. And culture and growth of organism is most definitive diagnostic modality for osteomyelitis. bone tumors. X-ray is to localize the tumor. CT scan is for external and cortical lesion. C. And MRI for marrow extent, M for M. Micrometastasis and soft tissue involvement. Most preferred investigation for most tumors is MRI. And PET-CT and bone scan for multiple lesions. PET-CT is better than bone scan. And biopsy is definitive diagnostic modality for any tumor. And here ends our discussion.